Alright, so let's move on to drug reactions. We're going to start with the cardiovascular reactions. As a disclaimer, you will see all of this information later on and throughout the different sections. However, I am going to introduce you to some of the major side effects of the different drugs. There are multiple sections of drug reactions. This is just the cardiovascular section. Now I'm going to pick out one or two from each group and then cover them. Now once you finish each section, you should flip back to this drug reaction review and quickly review some of the drugs that you just learned. Now, we're going to start off with the cardiovascular drugs and their side effects. Drugs that cause coronary vasospasm include cocaine, sumatriptan, and ergot alkaloids. Now, remember that cocaine users may present to the ER with angina. This is not very uncommon. This is not a rare event. Now, this is because a side effect of cocaine is to cause coronary vasospasm, which decreases the blood supply to the heart. And this can cause the chest pain, so make sure you tell cocaine users to stop. Now let's talk about the endocrine and reproductive major drug reactions. Not much to say about this one, however, we can tie in a nice little endocrine correlation here. So here's our drug reaction. Adrenocortical insufficiency. Now why would glucocorticoid withdrawal cause this insufficiency? Let's say you have a patient who decided to use copious amounts of cortisone cream to treat the swelling from his shoulder injury. Now, he used 2 bottles a day for the last 2 months trying to get his shoulder under control. That's a lot. He suddenly stops using cortisone and shortly thereafter develops adrenocortical insufficiency. In this case, the patient was using an exogenous, meaning it was not created by the body, an exogenous hormone which suppressed his adrenal glands. Now, since he's receiving the hormone exogenously, his body has no need to create it endogenously by the adrenal glands or within the body. So, since his cortisone is a glucocorticoid, it will exert negative feedback on his hypothalamus, which decreases the corticotropin-releasing hormone, which will decrease the adrenocorticotropic hormone from the pituitary. Once the cortisone is stopped, the body won't be able to ramp up its production quickly enough, so the patient is going to be vulnerable to adrenocortical insufficiency here, which can manifest as hypoglycemia, low blood pressure as well, dehydration, and maybe some cardiovascular problems as well. Now this drug reaction is going to be very well worth knowing because I can almost guarantee you'll see a form of this on your boards pretty much. Let's say you have a patient come in with severe diarrhea after being treated in the hospital for pneumonia last week. Now, the boards may give you a little bit more information about this patient, but light bulbs should be going off in your head already as to what this patient has. They have a C. diff overgrowth. Now, they have diarrhea after a hospital stay, being treated with antibiotics for pneumonia. An antibiotic got rid of some of the bugs, like pneumonia, but may have cleared out some of the other protective bacteria in the colon, thus allowing the C. diff to grow and cause a superinfection. Now, these are a few drugs worth knowing. What are they? It's going to be clindamycin, ampicillin, and cephalosporins. Since here at First Aid Express we are committed to helping you maximize your board score, let's talk about the treatment of C. diff. Now to treat this poor gentleman with C. diff, you're going to use oral metronidazole. There you go, oral metronidazole, and that is your answer. Now, if this is not an option, this is your first line agent, you're going to treat it the first time with oral metronidazole. Let's say that's still not clearing it, we need to give some oral vancomycin. Vancomycin, I think that's with a C. Spelling is not my strong point. However, you can almost bet that you will see this on test day in some way, shape, or form. The treatment of C. diff. Some drugs may also cause some blood issues. Now, the one that I'll talk about here today are the drugs that cause hemolysis in glucose 6-phosphate dehydrogenase deficiency, also termed G6PD deficiency. So do you even remember what G6PD deficiency is? Well, it's going to be a defect in the HMP shunt, which is used to create NADPH molecules, which serve to buffer oxidative cell stress. Since red blood cells rely on the NADPHs, if the enzyme used to make the NADPH is missing, which is this G6PD here, if that G6PD is missing, then the red blood cells won't be able to defend against oxidative stress, and then they'll lyse, leading to hemolysis. There are a few drugs that should be remembered that can bring about this hemolysis. So let's introduce them here. These include isoniazid, or INH, sulfonamides, dapsone, primaquine, aspirin, ibuprofen, and nitrofurantoin. A slang way that I remember this is hemolysis is depain, or is depain here in red. It represents the drugs that can bring about hemolysis. Notice how there are quite a few important drugs here under this section. However, the one that I want to emphasize specifically is going to be the tetracyclines, which may cause teeth discoloration. This can be presented on the boards by the following question. You've got a 5-year-old girl that's going to come in with her mother, who's obviously distressed because her daughter's teeth have turned a grayish hue. Now, I would be distressed as well. What drug is going to be most likely to cause this discoloration? And you're going to be prepared for this, so now you confidently put tetracyclines down as an answer and move on to the next question. Let's talk about another clinical scenario here. A patient comes to your clinic with hearing loss, ringing in the ears, which is also tinnitus, and blurred vision. Through your history, you note that they have a cardiac condition, which is currently being treated with quinidine. Now, what overall condition does this patient most likely suffer from? You've got a triad here of hearing loss, tinnitus, and blurred vision. Now, these three are typically associated with synchronism. Notice how up here, that's one of our drug reactions. Now, this is due to an overdose of quinine or quinidine. Typically, switching drugs will get rid of these symptoms. Make sure you're comfortable with the rest of these drug reactions, since neurologic drugs tend to make great board questions. The two main drugs that can cause diabetes insipidus as a potential drug reaction are going to include both lithium and dimeclocycline. Okay, so I know what you're thinking. Diabetes mellitus, that type 1, type 2 thing, it's so common in the real world. But what about diabetes insipidus? What in the world is diabetes insipidus? Well, simply put, it's a deficiency of ADH, or antidiuretic hormone. The name should give a clue to what the function is, antidiuretic hormone. So we can break diabetes insipidus into two subclasses. There's two types of diabetes insipidus. First, there could be a nephrogenic diabetes insipidus, where the kidneys are insensitive to ADH. That ADH, that antidiuretic hormone, is still being produced, just the kidneys aren't listening to it. Kind of like how my wife, sometimes she'll try and talk to me when I'm watching my Hawkeyes win basketball and football. She's saying words, just, I don't hear it. So it's kind of the same thing. The ADH is still being produced, just the kidneys don't react. They don't hear what the ADH is trying to say. So that's the first type. That's the nephrogenic diabetes insipidus. We also have a central diabetes insipidus. Now, central diabetes insipidus is where the body doesn't produce enough ADH. So what symptoms will a patient with this diabetes insipidus have? What can we expect to see? Well, these patients typically have excessive thirst and urine that's going to be extremely diluted. They are unable to concentrate the urine because antidiuretic hormone isn't working. Remember, lithium is going to be a mood stabilizing agent, and dimeclocycline can both cause diabetes insipidus. As you'll find out in the renal section, an important side effect of ACE inhibitors can be a dry, non-productive cough. You'll see this out on the clinic. If you see a cough described as dry cough on the boards, make sure that they're not taking an ACE inhibitor. If they are, you simply switch them to a different drug. Lastly, let's talk about the drugs that cause a disulfiram-like reaction. These include metronidazole, cephalosporins, griseofulvin, procarbazine, and first-generation sulfonylureas. So, what does a disulfiram-like reaction mean? Disulfiram is a drug that can be given to alcoholics to discourage them from drinking more. When ethanol is converted to acetaldehyde, the acetaldehyde buildup can cause the hangover effect, which includes nausea and vomiting. Disulfiram acts to prevent the body from further degrading the acetaldehyde, so when an alcoholic drinks, they're going to feel nauseated and they may vomit, and this hopefully discourages them from further drinking. Now, these drugs that I listed have a disulfiram-like effect, so you want to make sure that they aren't surprised when a patient describes these symptoms after drinking and taking these medications. What is the P450 system? The P450 system refers to a superfamily or a broad collection of enzymes that are going to be found mainly in the smooth endoplasmic reticulum of hepatocytes, so liver cells. In the liver, these enzymes catalyze the metabolism of both exogenous drugs and toxins and endogenous compounds. So we're talking about the P450 system right now because exogenous compounds, aka drugs, can affect this system. Here we have the liver and some drugs. Now the P450 system will work at a normal pace and spit out metabolites at a constant rate here. This represents the normal functioning within the body. There are many drugs that are going to be metabolized through this pathway. There are drugs that can be classified as inducers or inhibitors of this system. Now they're classified according to how they affect the P450 system. For example, inducers will speed up the P450 system. Everything that is metabolized by the P450 system will be affected since the P450 system is ramped up. The inhibitors slow down the P450 system. If an inhibitor slows down the P450 system, drugs can stay in the system longer. This P450 system can be induced or inhibited, and this is going to be the basis of many clinically important drug interactions. So you don't want to breeze over this section. I'm here to get you maximum points on test day and get you the best score possible. So I'm going to give you a quick tip. Make note cards on this subject. Know these in and out. Study them the night before your test or the morning of your test. If you do this, you won't let an easy point pass by. What are the P450 inducers? Now, the P450 inducers are drugs that ramp up the P450 system, which increases the liver metabolism of certain drugs. These can be remembered by the mnemonic chronic alcoholic Mona steals fen-phen from Barb and never refuses greasy carbs, which stands for chronic alcohol use, modafinil, St. John's wort, phenytoin, phenobarbital, barbiturates, nevirapine, rifampin, griseofulvin, and carbamazepine. Now, here is how I picture it. We've got two beautiful ladies, Mona and Barb here. Here's our alcoholic Mona, which is going to be stealing fen-phen from Barb, and that's not refusing some carb oval as well. Alright, so now that I have a look at this, apparently both of these ladies prefer the shaved head look because that is fashionable this year, probably taking after Miley Cyrus. Many drugs are substrates for the P450 system. These are the drugs that get metabolized by that P450 system, but don't necessarily speed up or slow down the system. These substrates can have altered concentrations in the body if an inducer or an inhibitor changes the speed of that system in which these get metabolized. Again, commit these to short-term memory if you feel overwhelmed in the pharmacology section. If you are following along in the book, we are almost done. I see the light at the end of the tunnel. Now, since some drugs induce the P450 system, it would make sense that some drugs slow down the P450 system. P450 inhibitors can be remembered by the following mnemonic: magic, Rex, and GQ. Now, some macrolides, such as erythromycin, but not others, such as azithromycin, are going to be your inhibitors. Amiodarone, grapefruit juice, isoniazid, cimetidine, ritonavir, acute alcohol use. Remember, chronic alcohol use can induce the system, but acute use can inhibit it. Ciprofloxacin, ketoconazole, sulfonamides, gemfibrozil, and quinidine. Now these are the inhibitors of the system. Now, to remember this, I just think of looking through a GQ magazine. Never actually read a GQ magazine, so I don't know what's in it, but I imagine that there's some magic racks for sale. So hopefully my artwork is so terrible that you won't be able to forget this on test day. On that test day, I hope you go to this subpar drawing during your test and think, dang, Tyler, this drawing was so bad that it actually helped get me the test point. Now, again, this is just pure memorization, plain and simple, so covering these lists a few times with note cards is often helpful. Sulfadrugs, or drugs that have a sulfonamide functional group, are often used as antimicrobials. However, certain diuretics, COX-2 inhibitors, and diabetic drugs can also be classified as sulfadrugs too. Many patients have allergies to sulfadrugs, so it's going to be important to recognize in the clinic where sulfadrugs are because patients can develop some severe reactions. Now, what drugs should patients with a sulfa allergy avoid? These tend to include probenecid, furosemide, acetazolamide, celecoxib, some thiazides, sulfonamide antibiotics, sulfasalazine, and sulfonylureas. Now, you can remember these with the mnemonic popular facts, where the FACTSSS stands for each of these drugs I just listed. Allergic patients can develop severe symptoms, which are pretty nasty, which can include fever, urinary tract infection, a pruritic rash, Stevens-Johnson syndrome, a hemolytic anemia, some thrombocytopenia, agranulocytosis, and an urticaria. Now, some of these reactions can be life-threatening, such as Stevens-Johnson syndrome. So if you're wondering what that is, it's going to be a severe drug reaction. Then also you can get agranulocytosis, which can be very dangerous. Now, here's the picture like I just said. Not looking too pretty there. So you'll want to avoid the sulfa drugs if somebody has a sulfa allergy. I hope you're ready for a practice question now. Let's see how these concepts we just covered can show up on the USMLE. A 78-year-old man taking multiple medications presents to the clinic for continued surveillance of 3 coronary stents that were placed about 4 years ago. Warfarin prophylaxis was started following his cardiac catheterization and stent placement. He denies any recent change in diet, but notes that another doctor started him on a new antibiotic. Coagulation studies show the prothrombin time is 14 seconds, the partial thromboplastin time is 36 seconds, the bleeding time is 5 minutes, and the INR is 1.05. Which of the following medications has the patient most likely recently begun taking? Is it A, erythromycin, B, griseofulvin, C, isoniazid, D, ketoconazole, or E, ritonavir? I'm going to give you a second to think about this. Alright, do you think you know it? If you said B, griseofulvin, you would be correct. Now, I told you that the P450 inducers, substrates, and inhibitors would be important. Let's see why the answer B is correct. Now, this question is saying a patient uses warfarin, which is a blood thinner. Warfarin affects the prothrombin time, or the PT, but not the PTT, or the partial thromboplastin time. These are some distractors. Next, we need to look at the actual value of the prothrombin time. So 14 seconds here. If the patient is given warfarin, we would expect this prothrombin time to increase. Looking at a reference value, we see that our PT is within the normal range. That means that the warfarin isn't doing its job correctly. This question expects you to realize that the liver's P450 system is metabolizing the substrate warfarin faster, decreasing the warfarin to subtherapeutic levels. Thus, we see a normalized PT time, the prothrombin time. So, what drug here is inducing the P450 system to ramp up its metabolism? Out of all the options here, the only one that is going to be an inducer is griseofulvin. So answer B. The rest are inhibitors. So in summary, griseofulvin was given, which ramped up the P450 system, which metabolized warfarin at a faster rate to subtherapeutic levels, causing the PT to normalize. Hopefully this makes sense, and just remember the end is in sight. Only one more short section to go. I hope you'll join me to finish off this pharmacology journey.